Chapter 8 of A Practical Guide to Therapeutic Communication for Healthcare Professionals. Now, you all got this book in first semester. It's a very small, thin volume. So I want you to pull it out and look at Chapter 8. Chapter 8 is all about communicating in the workplace. And remember, it's more than just patients. Chapter highlights workplace communication, the basics. This encompasses workplace etiquette. It's one of the first things we'll talk about it. Then we'll go on to communicating with team workers, your coworkers, your physicians, managers, regulatory agencies, and referral staff. We'll then go on to communicating when you're the one in charge or the lead, challenges and overcoming them, showing compassion without jeopardizing the charge role. Professional etiquette. Etiquette is the standard behavior that is acceptable in any given social, professional, or official setting. It has to do with respect, kindness, and civility. Accept each person's contribution. From the janitor to the surgeon, everyone is important and must be treated equally. Keep the workplace free from jokes or betting. Inappropriate subjects, such as those with a sexual connotation, betting, and lewd jokes, should not take place in the workplace. They can be misinterpreted and misconstrued. Maintain patient and staff confidentiality. It is inappropriate to discuss a staff's personal life. For example, Dr. Smith is getting sued. Oh, did you hear? Susie is getting divorced. Also, adhere to your organization's code of ethics. You're a respiratory therapist, so you want to make sure that you know the AARC Code of Ethics, and you want to make sure that any organization that you work with, you review their Code of Ethics as well. Interdisciplinary communication. Interdisciplinary communication is two or more types of healthcare professionals working together to meet a patient's needs. It promotes teamwork, which is an open dialogue among all team members and helps to strengthen the teamwork and thus increase productivity. It improves productivity and efficiency, improves the patient care environment, meets various regulatory agency standards. For example, JACO states there must be evidence of interdisciplinary communication in a patient's chart. It also helps to create or revise policies and procedures. The case conference or patient rounds. This is a cohesive group of professionals that coordinate clinical treatment. This can include nurses, doctors, respiratory therapists, medical assistants, social workers, physical therapy, nutritionists, clergy, etc. It can be formal or impromptu, spur of the moment, and it is required by some agencies such as JACO, Medicare, or Medicaid. Medicare and Medicaid require in skilled nursing facilities and subacute care facilities interdisciplinary case conferences to occur on a regular basis. Failure to have these meetings can result in Medicare not paying for the entire stay. So who's on the healthcare team? Well, your coworkers for one, other respiratory therapists, doctors, managers, supervisors, team leads, JACO, OSHA. Also, referral or consultation staff such as home care agency, consulting physicians like pulmonologists, social workers, dietitians, physical therapists, and occupational therapists. All are part of the healthcare team. Challenges among coworkers and other healthcare team members. Age. A 19-year-old new graduate may not interact well with a 60-year-old seasoned professional. They may have different goals and different objectives. One person may be retiring, while a younger person may be looking for a management role. They may have different job goals and different motivations. They may have different job focuses. Best friends can be tough at work. If you have a best friend at work, it can be hard working together. You may feel pressured to cover or support them during a difficult time. You may work with people that have different work ethics from you. You may be brought up with a work ethic where you always work really, really hard. Others may be more laid back. That can make it be hard to communicate with each other when you see things differently. Use the PEER acronym. Present the problem. It's important to explain the problem as you see it. I feel I'm always doing extra tasks. Avoid the word you, as in, you're not doing your share, because when you use the word you, it sounds confrontational. Explain the problem. It's important for you to explain how the problem makes you feel. For example, I feel really stressed and upset because of this, doing all these extra tasks. Again, notice the word I, not you. Saying, you make me feel stressed, is not therapeutic and doesn't help. Effect. Explain the effect. You need to explain the effect that the problem, such as too many tasks, has on your ability to do your work. For example, since I've been stocking all of ICU with all the new respiratory care equipment, I haven't had any time to do my ventilator checks. Notice the avoidance of the word your. Saying, since I've been doing all your work, I haven't had a chance to do mine. That's argumentative and sarcastic. Try to avoid that. The initial one saying, since I've been stocking the whole ICU with all the new respiratory care equipment, I haven't had time to do any of my vent checks. It will lead to a solution. And then resolve. Explain how you want to resolve this problem. It's important that you state that you want to resolve the problem so there's teamwork. For example, I would like us to work together to stock the ICU. Then we'll both have time to do our work. Saying something like, you need to stock that ICU, not me, will not improve or resolve the problem. Let's talk about some good and bad phrases to use with your coworker. When someone does a great job, tell them, hey, You did a great job. Asking for advice when you need it is just fine. I need some advice. Susie, can you tell me a little more about that ventilator? It's new to me. Or let's talk about it. Let's try it this way. Can I make a suggestion? Those are all phrases that are non-threatening. Saying things like, are you crazy? Are you out of your mind? You're just lazy. And I can't help you with that. All are provocative and don't help the situation. Tips for talking to physicians and for when to contact them and why. STAT. STAT means something's a priority. It means it's right now. The situation is life-threatening. There's a sudden deterioration in a patient's condition, and you need to talk to them pronto. Urgent. Urgent means you need to address the situation promptly, but it's not an emergency. Things like changes to medications are urgent. Patient care concerns that require urgent care are things like a nebulizer to go home with. It's urgent, and you need the physician to call you back, but it shouldn't be page stat. And then non-urgent things like scheduling changes. Those are non-urgent. When talking to physicians, physicians can be intimidating. People new on the job or new to the physician may feel intimidated when talking to them. Don't. You need to be your patient's advocate. Introduce yourself, say hello, explain who you are, and don't be afraid to talk to your physician counterpart, even if you're new. Be aware that all physicians are a little bit different. They all have different personalities, different likes, and different needs. Some of them can be a little prickly, but none of these should be a reason why you don't communicate with your physician. And I encourage you to get your manager involved if a physician is particularly non-communicative or particularly difficult. When talking to physicians, use the doctor acronym. Describe the problem. Mrs. Brown seems confused today. Be sure you use language that's comfortable to you. Don't use fancy medical terms that might confuse the communication. Give your observations. What did you see? I went into the patient room at 10 a.m. and they were not as awake as they were at the 6 a.m. treatment. Tell them about the clinical signs and symptoms that you saw. Mrs. Smith was more short of breath at noon than she was at 8 a.m. What treatment did you give? I gave Mrs. Smith her PRN treatment and her breath sounds improved. They got much louder. So give the observations that you saw after the treatment and then give the request for a change or an difference in the treatments. So Mrs. Smith remains short of breath. I think we should change her treatments from PRN to every 4 hours, at least for the day. When talking to managers can be another difficult situation. When should you call them? So, tips for contacting managers. Call managers when it's emergent. Emergent things are unusual patient care situations, unannounced or unplanned regulatory inspection, patient care situations that need immediate attention, life-threatening patient care issues related to adverse medical treatment or an unexpected patient reaction, or a patient death. Urgent situations are a procedural question that might affect patient care. Immediate or upcoming staffing problems, for example, someone that just called in sick and now there's a significant hole in the present staffing. And then non-urgent things are scheduling requests, vacation requests, and general communications like, I just renewed my CPR card. Some challenges that you might find when you talk to your manager. The manager may cover more than one site, so they may not be on site, or you may work a different shift. You may be on nights and the manager may work during the day. That makes communication particularly difficult. Age differences. The manager may be younger than you, so it may be difficult to talk to the manager if the manager is older or younger than you are. Remember that all managers have to make unpopular decisions, and sometimes it's hard to understand the reason why. It's okay to ask for clarity around an unpopular decision. Unpopular decisions sometimes lead to resentment with the staff, but by asking for clarification, it can relieve some of that resentment when it's understood why they made a decision. Again, use the PEER acronym when speaking to your manager. Present the problem. So, Joe, I have a problem with my schedule. Notice the avoidance of the word you. Joe, you need to fix my schedule. Explain how it makes you feel. This schedule is difficult for me because of my daycare situation. Explain how it affects you. Joe, it really makes me feel stressed and anxious when I have to really, I'm not sure how I'm going to get the daycare that I need. And then offer a solution or a resolution to the problem. Hey Joe, I noticed that my daycare is open late on Mondays, so can you see if there's anybody that's willing to switch with me my Tuesdays for Mondays? Having a resolution in mind and offering a solution will promote open communication, even if it doesn't work out. Good and bad phrases when talking to a manager. These are some things that managers like to hear and some things managers don't like to hear. And remember that a manager can be a team lead, a supervisor, or anyone in charge. Things that you want to say with the manager. You can count on me. I'll be there. Yes, you have a good point. I'll make sure that I do that next time. Thank you for this opportunity. That sounds great. Or, hey, I have an idea. Can we talk about it? Please don't say these things. It's not my job. or I can't do that. It's not my fault. It was the nurse's fault. This is a waste of time. I don't want to do this. And another one of my personal favorites was, we've always done it that way. It won't work if you do it that way. Let's do it this way. Please try at least. Regulatory agencies such as JCAHO can be particularly challenging when it comes to communication. They can have confusing language and standards. For instance, a standard may be Standard 158.36, Part 2 of Section 3.2a. Now, that's a mouthful, and it can be confusing as to which standard is which. Regulatory agencies, just like physicians, can cause fear and intimidation, especially in newer therapists or students that are not used to the workplace. Just know that even though it's scary talking with a state health inspector, if you know your job and you know that your workplace is meeting all of the regulations, the process won't be that scary, and that your manager will be on board with you. It's everybody's job to stay current with what the regulations are. And sometimes there's pressure from a manager, a supervisor, or a team lead. The manager might say something like, "Make sure everything is perfect for JCAHO." Don't say the wrong thing. However, if you have a really good manager, they'll be there for you, and they'll help you and let you know that they're on your side. When talking to regulatory agencies, use the acronym AGENCY. Answer the investigator's questions truthfully, honestly, and professionally. Don't be hostile or argumentative. For example, don't say, "I'm too busy to answer your questions right now. The information's right here. Didn't you see it?" Give the appropriate information, not more, not less. Encourage an open dialogue. Never hide information. In many cases, it's illegal to hide or conceal information from an investigator or regulatory agency. Follow HIPAA rules and guidelines about confidentiality. For example, in a child abuse case with a child abuse investigator, that investigator might have access to part of the child's chart, but not other parts, and they may not have any access at all to a parent's chart. So only give them what they're allowed to have. And then your attention, always give them your full attention and support. For example, "I'll be here at the desk if you need any more information." Let's talk a minute about referrals and consults and the difference between the two. Referrals are a formal contract to provide services. A referral agency will do a particular service. A physician may send a patient for a referral to an ophthalmologist to treat an eye problem, but a primary doctor continues to care for the patient for all the other problems. Consults are a little bit different. Consultations are recommendations for treatment. For example, a doctor may send a patient to a vascular surgeon for a consult about a wound. However, the surgeon will make recommendations to the primary doctor, who then decides on the plan of care. At the same time, he may send the patient for a consult to a wound center for their recommendations. Sometimes the consultation takes place by telephone. Sometimes it takes place via telemedicine. Basic information that you need for a referral. Types of services needed. For example, I need pulmonary rehab services for my patient. Dates of services. When they should begin. How long are they? What are the goals of the service? And any specific instructions. Use the consult acronym. Clarify any terms. Before calling, be sure you understand the referral form and you can read the instructions. Give objective data that's needed, such as age, sex, PFT data, phone number, reason for the referral. Give any necessary past history. Also, give any signs or symptoms such as vital signs that the referring agency may need. ABGs, PFTs, shortness of breath. Talk about any unusual circumstances. Unusual circumstances usually fall under patient is deaf, patient is blind, patient only speaks Polish and will need interpreter services. And looking, explain what services you're looking for. For example, she needs pulmonary rehab 3 times a day for improved shortness of breath and improved strength training. And tell when services should start. Time. Services should start within the next week. Be clear. Let's talk a little bit about communicating when you're the one in charge. It can be difficult when you're the one in charge, especially when you're new to the role. All of you at some point will be in charge. Peer competition. A peer or coworker may feel that they have seniority and deserve the charge role. This can be tough to work with and tough to talk to when you're working with these peers. You also may no longer feel like one of the gang. For new charge people, the role can be difficult because you may feel alone and not really part of the staff and not really part of the management yet. When communicating as a manager, lead therapist, or as a supervisor, use the BOSS acronym. Behavior. Explain what behavior you noticed. Hey Joe, I noticed that you didn't do your quality checks. You should have been checking on whether all those alarms were on. Provide objective findings. Hey, when I noticed that this form on whether that ventilator has been plugged in and whether it was serviced hasn't been done for over a month. It's supposed to be done every single month, and you were the one on that night and tasked with that area. Explain the spread and effect. When this kind of quality check on that ventilator isn't done, patients can suffer. In fact, if the ventilator isn't working, there can be a delay in patient care. The patient could even die. And then suggest or search for resolutions. So saying, I was thinking that maybe we could set an alarm on the phone that you carry on the day that that check needs to be done, on the first of the month. And that would tip you off that it needs to be done so you could remember. As a manager, you'll have to learn the art of delegation. Delegating is the process of assigning a project or a task to someone other than yourself. And competency is a verification that the staff member has been trained and successfully passed an evaluation for a given task. It's important to assess staff competency before delegating a task. Ask yourself, can that person accomplish the task safely? Use the P rules. Don't pressure, preach, or punish. Do praise, persuade, and promote. Communicating with support and compassion is really important whether you're a peer or a manager. You want to use empathy, which is understanding and caring. As a manager or a peer, it's important to show empathy for your staff's problems. However, it's not possible to have sympathy for everyone's problems. You need to understand the problem and anticipate the effect that the problem might have at your facility. Empathy is understanding and caring. Sympathy is being sorry for someone. Empathy is walking a mile in someone else's moccasins. Sympathy is being sorry that their feet hurt. So please, empathy will take you a million miles further than sympathy ever will. In summary, I want you to think about these questions. How can you, in your next clinical rotation, apply this chapter to your new job that you're looking for, your new RT job, your next clinical rotation? What are some of the challenges of using this information at your new job as an RT or your next clinical rotation? And what are some of the benefits to using this information in your next clinical rotation or at your next job? Thank you. This is the end. Awesome you are.